Now starting. All attendees are in listen-only mode.
Good morning, everyone. Today is Thursday, May 7th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to DDA's Appendix K Guidance Webcast. Excuse me. Thank you for joining us today. We have several DDA presenters today. We have Patricia Sestoki, Director of Programs, Rhonda Workman, Director of Federal Programs, Mary Jane Asazua, IT Functional Analyst Supervisor, Valerie Roddy, Director of Fiscal and Operations, and Peter DeFries, Director of Operations. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There's only one option to listen to the webinar, and that's by computer. There's a handout for the webinar, and you can find it in the handout section on the panel on your right. It can be emailed also. We are recording the webinar and we will post it on the DDA website. Questions can be typed in the panel in the chat box or question box on your right. And now I'd like to introduce Patricia Sestoki. Good morning.
And Donna, thank you for the introduction. Really appreciate it. Valerie and I would like to welcome you to our last series of webcasts in reference to Appendix K. We have enjoyed being with you all week. And as you know, our Deputy Secretary Bernard Simons has instructed us to create operational guidance to implement Appendix K. So we try to streamline and make it as simple, as easy as possible, knowing our constraints with PCI's 2 system. Today, you will hear from our operations and programs team. But first, I want to make sure you know the DDA's highest priority is the health, safety, and well-being of people with intellectual and developmental disabilities, their families, staff, and providers. As you heard our Deputy Secretary share this during his Friday webinars. Today, we'll be going over staff training and onboarding flexibility, service delivery in alternative settings, and out of state, site capacity, license maximum and exceed group size, one-on-one and two-on-one exceptions requests. There's going to be a quick poll between each section, and we're going to open it up for questions on that specific topic. We encourage you to submit questions to the DDA website that we have of the DDA toolkit, and we're going to populate the answers and post them on the DDA website. If you visited our website already, you will notice that under Appendix K, we have frequently asked questions updated on May 5th. I would also recommend that you go through those Q&As before you submit additional questions, as your question may be already answered in that document. So before we get started, I'd like to ask Valerie if she would like to share anything before I turn this over. Valerie?
Thank you, Patricia, and good morning. First off, I'd like to let everyone know how much we appreciate your participation in the webinars and webcasts this week. This information is critical not only for the DDA, but most certainly for our providers. We can't do our jobs without you. So we really do appreciate your participation. As always, if you do have questions, and there's a lot of material that has been covered this week, please feel free to use the toolkit email account that has been posted in these documents and on our website. Or if you've got a fiscal or an operational question, please feel free to contact our service desk. With that, I will turn it back to Patricia.
Thank you, Valerie. So please know that as we go through all this information, we want you to process it, go back and look at the at a glance, go back and look at the memos, think about how this is going to impact you, how you're going to implement it and operationalize it. And if you have any specific things that you're stuck with, please again reach out to us through those emails, as Valerie have said. I'm now going to turn this over to Rhonda Workman, our Director of Federal Programs. Rhonda?
Thank you, Patricia, and good morning to everybody. Donna, can you go to the next slide, please? So first, we're going to talk about the provisions for staff training and onboarding flexibilities that are noted within our approved Appendix K. And so to maintain and support expansion of the current workforce, we've made modification to our current staff qualifications that are noted within our approved waivers so that we can provide more opportunity and options to meet people's needs. The DDA received recommendations initially from the Developmental Disabilities Coalition on some items that we could include for staff training and onboarding flexibilities, which were incorporated into our Appendix K request and have since been approved. The DDA memo number 6 outlines these flexibilities, and this guidance applies to both our self-directed and our traditional service delivery models for the following items that we're going to talk about today. Given the shortage of direct support professionals, providers are encouraged to utilize all staff in the provision of direct support. This includes management and clerical staff as examples, and the training exceptions and expectations for their staff, this clerical and management staff that could be used, is the same as described in this guidance that we're going to be talking about. Providers are also encouraged to work with participants and their families to explore the availability of natural supports if needed and as available. Please note that the options we are discussing today and outlined in our guidance provide temporary extensions to timeframes or may waive a requirement altogether for family members. These exceptions apply under the Appendix K authority only and will end on March 12, 2021, unless otherwise noted in our guidance. Next slide, please. In the event that natural supports are not available, providers or participants enrolled in the self-directed service delivery model may hire relatives and legally responsible individuals to provide services. This also includes the hiring of spouses and parents of minor children. Providers and the fiscal management services providers supporting participants enrolled in our self-directed model are encouraged to track spouses and parents of minor children that are serving as staff separately, as this again is only a temporary provision. Under the legal and relatives that are available, providers may provide services using a relative or legally responsible person in a variety of services, including our community living group home services. Due to individual situations during this emergency, and as indicated in the guidance, services can be provided in alternative sites to include a family's home. Participants self-directing and providers must ensure services are provided as authorized in the plan and that billing occurs as per DDA's requirements. Relative and legally responsible individuals should receive training on the participant's specific needs as set forth in their person-centered plan, and if applicable, nursing care plans and behavior plans for whom they are rendering these services. Training on the participant's specific needs must consist of basic health and safety support needs for the participant, including but not limiting to dehydration, seizures, and other things that would support their immediate health and safety. In an effort to expedite service delivery during this pandemic, training requirements may be waived for family members willing to provide services to participants up to 60 days following the end of the state of emergency. In other words, family members can begin providing services and not required to go through all the training. Next slide, please. Additional onboarding flexibilities include hiring individuals 16 years of age or older, including family members, neighbors, it could be a certified babysitter or others that meet the revised qualifications that are set forth in the guidance. 16-year-olds can provide direct support for waiver program services that normally require the direct support professional to be 18 years of age or older. Individuals 16 years of age but younger than 18 years of age must be determined responsible. To be determined responsible, the participant or the participant's legal representative, if the participant is enrolled in the self-directed service model, would make that determination, or the provider if the participant is enrolled in our traditional service delivery model. Another option includes direct support professionals, exception that they do not need to have the high school diploma or GED certificate in order to provide services. Again, we're looking at our staff qualification requirements in our waiver and looking for ways to make them more flexible during this crisis. In terms of criminal background checks, a provider who chooses to use non-traditional staff and direct support positions must initiate appropriate background checks and the motor vehicle checks if driving. But they may place the person, that staff person, on the schedule immediately after performing an abbreviated background check using the name of the person, their birth date, and social security number for the potential new hire. For all training and onboarding flexibilities, providers should maintain a list of the staff hired under these exceptions because these exceptions will expire and will not continue after the pandemic or as noted in the guidance, and be able to have that available upon request from the DDA. Next slide, please. As noted in our guidance, to expedite the hiring of staff and their ability to work with people immediately, we have temporarily waived all but the most essential staff training requirements for direct support professionals under both the self-directed and traditional service delivery model. Again, in an effort to expedite this, training requirements may be waived for family members willing to provide services. For new employees, providers, and participants enrolled in self-directed services that utilize that abbreviated training format for the purpose of accelerating the onboarding of direct support professionals must ensure that all employees meet pre-existing annual training requirements within 120 days of onboarding. For current staff, current employees, annual training requirements for direct support professionals, as provided in the guidance, who have previously completed all the training requirements will be extended 90 days after the state of emergency. Therefore, if one of their trainings has expired and they're due to renew it, at this time that can be suspended until the state of emergency has ended. The essential training, as noted in our guidance, that will still be required for direct support professionals prior to working with a person during the crisis includes the completion of online Cpr and First Aid training, which can be completed through a variety of different tools and methods. Staff without current Cpr and First Aid may provide direct support as long as they're working with a registered nurse or at least one other direct support professional who has CPR and First Aid certification. Again, expired certifications are not required to be renewed until 90 days after the state of emergency. Training on the participant's person-centered plan, and if applicable, a nursing care plan or behavior plan, for whom the staff will provide direct care as provided in the guidance, is still required. Basic condensed training in fundamental rights, including abuse, neglect, restraint, and seclusion, is needed. Condensed training in DDA's policy on reportable incidents and investigation can also be provided. Please note that training in medication technician training is not waived for direct support professionals, but we have modified as noted in the guidance. All staff who are responsible for administering medication must have training in medication administration provided by the Board of Nursing. Direct support professionals who have taken and passed the MTTP courses may begin administering medication immediately. And MTTP licenses current as of March 13, 2020, but expiring between March 13, 2020 and the end of the state of emergency, shall not be required to be renewed until 90 days after the state of emergency. and registered nurses are temporarily exempt from receiving the training from the DDA related to delegated nursing until the state of emergency is terminated. In terms of the person-centered plan and nursing care plan and the behavior plan, all direct support professionals, again, must receive those trainings on the specific needs. In respect to the behavior plan, if the participant has one, MANT training requirements shall be suspended at this time and are not required unless the staff person maintains a direct support position 90 days after the state of emergency. All direct support professionals assigned to support this person who has a behavior plan should receive training on the behavior plan by another direct support professional who has experience supporting the person or a supervisor prior to working directly with the person. Providers also have the option to provide a condensed training for DDA's policy and reportable incidents, and at a minimum, they should include the definition of reportable and serious incidents and the procedures for reporting as per your policies. Again, all of these exceptions and flexibilities is important for you to maintain lists of staff who have received abbreviated training so that you can then follow up with them to make sure they meet all the training requirements after the state of emergency. Next slide, please. Providers may also waive the basic health screen and PPD skin test as a condition for employment initially, including legally responsible family members. Providers may temporarily waive certain license requirements for healthcare professionals. This is in accordance with the executive order that was issued on March 16th. This includes the ability to hire any person who holds a valid, unexpired license as a healthcare professional in another U.S. state to practice within the scope of Maryland, such as nursing. Also hire an individual with an inactive healthcare practitioner license. Providers may continue to use staff with an expired license and other authorization issued by any agency of the state of Maryland. Again, this is in reference to the governor's order issued on March 16th. Providers may also share staff with other providers to support participants, especially during challenging times or shortage of staff. A written document can be accepted from a direct support professional's primary employer stating that they have required training and background checks in order for them to work for a different provider agency. These employees must still receive specific training regarding the person's needs and services as set forth in their person-centered plan, nursing care plan, and behavior plan as applicable. And services to be provided to the participant should be, again, as per that person-centered plan. Site-specific emergency response training should be provided to the new staff member, and this training can be condensed at the discretion of the provider and should be documented and kept in the personnel records. Next slide, please.
So Donna, will you run our poll for this section before we open it up for questions?
Yeah. Okay. Can I hire staff if an abbreviated criminal background check has been completed? Please select yes, no, or I don't know. And we'll give you a few seconds to answer. Okay, so it looks like 88% said yes. 8% said no. 4% said I don't know.
Thank you, Donna.
The answer to this question is yes. You are able to hire staff if an abbreviated criminal background check has been completed, as we shared during this presentation and as noted in our guidance.
Thank you, Rhonda. I'm now going to read questions from our question box. And the first one that I'm going to read is, there's a lot of questions already on one-on-one supports, but I'm not going to ask this until we get to that section. So I'm going to specifically ask questions about our this chapter. Okay. I'm just going through all the beginning was people couldn't hear. Can family members be hired if they are not comfortable with anyone else coming into their home due to safety for person supports?
That's a great question. The answer is yes. As per our discussion today and in our guidance, there may be some training and requirements that need to be met, such as the criminal background check. But yes, family members can be hired to provide services, including legally responsible individuals, parents of minor children, and spouses.
Okay. Are we able to hire family as a 1099 type vendor? This would allow payments to be made directly without going through a payroll, similar using staffing agency.
That's another great question. Under the self-directed service delivery model, the participant, as the employer record, makes that decision as to whether to hire individuals as staff or to utilize a vendor.
If the state emergency order is lifted, how does this affect Appendix K and the effective end date?
So that's another great question. CMS has provided the opportunity for Appendix K to be in place and available for up to 1 year. In the event that the state of emergency has ended before then, and the Deputy Secretary makes the decision to discontinue the provisions in Appendix K, information would be shared with stakeholders.
Are family members and legal guardians required to have a criminal background check?
Yes.
Can you expand on where we do checks using the name, birthday, and social security number?
So there are different options available. The DDA would not provide specific ones to use. That would be at the discretion of the provider, but there are options available that can be explored.
Okay, I'm going to read a couple of more before going to the next chapter. What constitutes an abbreviated background check?
So that's a good question. There are vendors and entities where you can enter information, some basic information, such as the person's name, their date of birth, and their social security number. And from that, the vendor, that entity would do a search through their systems to identify if there are any criminal records associated with that person's name, date, and social security number.
Does the training extension also apply to support workers whose recertification is coming due?
That's a great question. Yes, the extension for expired licenses and certifications as per the governor's order applies to all certifications and licenses.
Does family have to become med-tech trained if they are a direct support staff?
So under the self-directed service delivery model in our guidance, we included the option for participants self-directing to waive that requirement. Under the traditional model, as we discussed in our slides today, there will need to be, the training needs to be completed.
Does the training certification extension include extensions of MAN instructor certification?
That's another great question. We have shared information on our website in addition to information, our FAQs related to the certification. And so there is the ability for people who are trained and certified in Ament to continue to provide those supports, and there will be an extension to the opportunity to renew that. And so you'll see that in our FAQs. But yes, that is an option available.
And this one I'm going to read before going to the next chapter, only just because there's a confusion. Rhonda said training is waived for family members, but page 3 of Appendix 6, number 3 states they should have PCP, nursing care plan, BP training, etc. This is confusing to me. Can you clarify?
Yes, great. And I'm sorry that the information is causing some confusion. In Appendix K, we outlined information in our guidance related to the different provisions. And so under the heading of relatives and legally responsible individuals, we outlined what they could provide and what would be needed. You'll see on the next page, I believe you referenced page 6, we talk about provisions and exception opportunities that providers and participants self-directing can exercise. In that heading under our training, we note abbreviated training that is required. We also noted that based on the decision from the participant or the provider, they may have the option and can exercise the option to make an exception to the training for family members. If they make that choice, then the requirements for the training for person-centered planning, the nursing care plan, and the behavior plan that we noted under the category of relatives and legally responsible individuals could be waived.
Okay. And I'm going to just read this one because it came in after, and I know you've answered this and it's on the document, but it says if state of emergency is lifted, I hear you say the Deputy Secretary makes the decision to end. Would providers be given time, 30, 90 days, to end provisions in Appendix K, or will it be immediately?
So that's a great question, and absolutely, we will provide opportunities for readjusting and realigning. You will see in Appendix K, and as per we shared in this presentation, that some of the training and provisions are waived temporarily, but must be completed within 120 days of being hired, or are completely waived until 90 days after the end of the state of emergency. And so that will provide opportunities to look at and to readjust and ensure staff are appropriately trained and meet the standards.
Thank you, Rhonda. I am now going to go over to the next chapter. I'm turning it back.
Okay, so for the next chapter, we're going to talk about service delivery in alternative settings and out of the state. Appendix K provides these opportunities for services to be provided in alternative sites due to the potential need to relocate people because of isolating people who may have positive COVID-19 determinations, to separate people who have been exposed, to separate people due to maybe some behavioral challenges or other circumstances that could be associated with the COVID-19 state of emergency. All services provided in alternative settings minimally require documentation in the person's file, including the date of service, service provided, time of service, the location of the service, and the name of the person that provided the services. Providers must submit documentation upon request by the DDA. In addition, some participants may need higher level of support that are provided in acute care hospitals or during a short-term institutional stay. During these hospital and institutionalization stays, CMS is allowing communication assistance, behavioral support assistance, and personal care supports that do not duplicate services provided in the institution or hospital. They can be provided for participants while the participant is in that hospital or institutional setting. The participant staff can provide that communication support with hospital or institutional personnel to ensure that the overall health and safety of the person admitted, particularly if they cannot speak or have a difficult time communicating their needs, wants such as pain, reactions to medication, or thirst and hunger. This staff advocacy and support will be essential. Staff may also be asked to provide behavioral support In other words, implementing approved behavioral plan or emergency safety plan strategies in the hospital or institutional setting to again ensure the overall health and safety of the person and also the health and safety of the hospital institutional staff and other patients. The staff providing the services and supports should be knowledgeable from a person-centered and a hands-on experience rather than a clinical perspective of the participant's baseline, communication style, and how to effectively redirect and how to support the person in an unfamiliar and potentially frightening environment. The following services, as listed on the slide, can be provided during an acute hospital or institutional stay. This includes our community living group home services, supported living services, personal support, community development services, and day habilitation. Next slide, please. Services can also be provided in other alternative sites, including but not limited to a participant's home, family or friend home, alternative facility-based settings, staff or direct care worker homes, hotels, schools, churches, and other community established sites. Services may also be provided out of the state of Maryland in neighboring states and the District of Columbia. Services provided in an out-of-state provider owned and controlled setting will require a provider agreement with the out-of-state provider. Services may also be provided by DDA licensed or certified providers and self-directed service staff in privately owned or leased sites out of the state of Maryland in our neighboring states. Next slide, please. Providers must notify the DDA when any of the following. 1, services is provided in an acute care setting or short-term institutionalization stay for the services we noted on the previous slide, including community living group home, supported living, personal support, community development services, or day habilitation. Community living and group home or supported living services provided in an alternative site or out of the state of Maryland also requires notification. And finally, we would like notification when community living group home site capacity is exceeded. Next slide, please. The process to notify the DDA of any of those situations includes the provider completing a dedicated specific form. Providers will complete the DDA COVID-19 Site Notification Form, DDA COVID Form number 2. They will send it via a secured email to the DDA Regional Office dedicated email account, and providers shall also send a copy to the Office of Healthcare Quality for licensed site-based services at a dedicated email address listed here. This is simply to notify the Office of Healthcare Quality that the services are being provided in a different site so that if future reviews, there will be that documentation already noted. It is not to trigger any other action on behalf of the Office of Healthcare Quality. The email subject line for the email, the secured email and form being submitted to the DDA Regional Office should include, as the example is noted on the slide, the name of the provider, hyphened with COVID-19 alternative site, and then the date of the email. Next slide, please. This is the DDA COVID-19 site notification form. It has been uploaded onto the DDA website. This form can be completed for one specific person or can be used by providers to indicate several people. To complete this form, you will follow the instructions on the top of the form, including entering the person-specific information, such as the person's Ltss ID number if known, their PCIS2 ID number, and first and last name. Then you would enter the service site address, and for community living group homes that are exceeding current license capacity, you would enter the OHCQ authorized license site capacity number. And then next to that box, you'll enter the number of people currently being supported at the site. This number would be the number that's representing exceeding that capacity. For services being provided in alternative sites, you would enter a classification for the site. such as family home, staff home, hotel, hospital, etc. Or you can enter other and then indicate with a descriptor about what the other site is. Remember, the community living group home services can be provided in a family home, so you could indicate that here. You'll enter the site purpose, such as to isolate or guarantee or quarantine or due to behavior support needs. And then enter the effective date for the alternative site, exceeding capacity, or being served in out of state. And then the last column on the right in yellow, you would enter yes or no if the alternative site is provided in an out of state of Maryland. The form is submitted to the DDA Regional Office dedicated email address listed in the guidance and also included on this slide in the upper right side. DDA will acknowledge receipt of the email from the provider and log the information into a tracking sheet so that we're aware of where people are at and the notification. And we will also send an email to the participant's coordinator of community services to alert them to the alternative site. Next slide, please. Coordinators of community services being alerted with that email should enter in their progress note into Ltss the details contained in the email. They should monitor the provision of services in these alternative sites, such as the acute care setting, alternative facility-based sites, hospitals, etc., by contacting the person via telephone on a monthly basis at minimum for out-of-state services. They should document the contact within their monitoring and follow-up forms and wellness check progress notes. CCS should inform the DDA regional office of any discrepancies in terms of the information that is noted in the alternative site with their monthly and wellness check. And as appropriate, based on the information or findings, they should file an incident report if applicable. Next slide, please.
So, as noted in the guidance, the billing and the payment process is the same as it currently is for these services that are provided. If the person being supported has been determined as COVID-19 positive, then please follow the guidance for the increased rate when supporting people with COVID-19. Next slide.
So Donna, let's run a poll for this section, and then after that, we'll open it up for questions.
Okay, this is true or false question. Services can be provided in a direct care worker's home, hotels, schools, churches, and other community established sites. Please select one, true or false. And we'll take a few seconds, excuse me. Okay, 96% of you said it's true.
And yes, that is true. Services can be provided in a direct care worker's home, hotels, schools, churches, and other community established sites. So again, the answer is true, and that's an option available.
Great, thank you, Rhonda. I am now going to read questions specific to this section. And I'm just looking to see if anybody's posted anything for this section on these questions. Let's see, I left off right here. So I have not seen any questions posted for this particular section in our website. Let's see, let's wait a few seconds. Just for clarification, this form number 2 under the instructions does not give an option if providing services in one's home. For example, day services is one home. So does this actually need to be done for remote services, or if a day program, if the day program providers provide services in a residential group home?
That's a great question, and the answer is no. We are not looking for day programs to notify us if they're providing services remotely in a person's own home or residential home. The form shall be completed when the participant receives services in an acute care setting or hospital, and when services, community living, group home, or supported living services only are provided in an alternative site or out of state. And the third reason would be to notify us of the community living group home site capacity being exceeded. So those are the three reasons for why you would complete the form.
And if the regional offices was already notified of the site changes, do we still need to complete the this number 2 form?
That is a great question. I would recommend that you do submit it so that we can make sure it's recording on our tracking.
If you have a participant who were provided supports for a volunteer job under CDS, and you now provide remote supports on employment readiness, do you need to file a site change form?
No, again, meaningful day services being provided in alternative sites do not need to complete the site notification form.
When a person moves out of a group home and starts being supported by a family in a family home, this changes staffing ratios both at the group home and in the family home. How do we handle this authorization and billing? Valerie, would you like to answer that?
So the person who is being moved to an alternate site already has a rate for payment associated with those services. So that should just continue to be billed that way. It really doesn't, it should not affect the rate paid for the other individuals in the home.
In general, for all new service requests, is there still a requirement for a team agreement? Is there a notification process for the CCS other than approval email after the fact?
So, yeah, that's a good question. And yesterday we talked about new service requests. And so I recommend you looking at our guidance and also the webinar from yesterday. But in these situations, what we're requesting is agreement from the individual or the legally responsible person. The provider can get that agreement and they would indicate it on our new service request form. So a complete team meeting and team agreement is not required because we recognize the immediate need for health and safety services at this time. I would say also that if a coordinator of community services has concerns related to services being provided, that they can reach out to the regional office and share those concerns.
The form does not have an end date. If we had to move someone in order to quarantine for 14 days and that time is over and they have gone back to their home, how do we indicate that end date has happened?
That's a great question. I would suggest that you notify the DDA regional office. We'll take that back and look at our options for to help support that being streamlined.
What if the family is providing services in a non-neighboring state? Does this still count?
No, at this time, out-of-state services, we're really authorizing the ability to provide that in our neighboring states, recognizing that there may be a need to cross over the borders to support people maybe in a hotel or other sites. So we're really only looking at neighboring states.
Okay, I'm going to move us to the next chapter and turn it back over.
Great, thank you. This next section is about our site capacity and exceeding the site.
Rhonda,
the provider's
can
license.
I ask you, Rhonda, can I ask you to read that again or talked about that? You're going in and out.
Sure, I'm sorry. Is that better, Patricia? Can you hear me?
Yes.
Okay, great. So this next section is about our site capacity for our licensed community living homes. And so the provider's license capacity, meaning the maximum number of individuals who can be served in that licensed service location as approved by the Office of Healthcare Quality, may be exceeded to address shortage in staffing or accommodate use of other sites to isolate people who have a COVID-19 determination, to separate people who have been exposed, to separate people due to behavioral challenges or other circumstances associated with the state of emergency. We recognize that people may be temporarily moved into different homes and sites that may exceed that number that was originally approved. Next slide, please. Providers may temporarily relocate participants based on that health and safety needs without pre-authorization from the DDA. Providers may exceed their current license site capacity without pre-authorization from the DDA. License site capacity will not be adjusted in PCIS2 or the Ltss Maryland systems when this occurs. Providers must notify the DDA when the license site capacity for the community living group home is being exceeded. Next slide, please. As we just mentioned, the process to notify the DDA about exceeding the site capacity will be indicated on the DDA form number 2, the site notification form. Again, the provider will send a secure email to the DDA regional office dedicated email account. In the subject line, it should read the name of the provider, followed by COVID-19 site form, and then insert the date. The notification should also be sent to the Office of Healthcare Quality just to alert them that that number will be exceeded. Again, they're not to act on any action related to that. It's so that they'll have that in their file for future reviews of documentation. Next slide, please. Here again is the DDA Kovat form number 2. And as we mentioned previously, the provider would complete the information about the person specific. This form can be completed to indicate several people that are associated with the licensed site capacity. To complete it again, the provider would, for community living group home, note the current license capacity and also the current number being supported. That is the new number that is exceeding the capacity. They'll also enter the effective date. The form is again submitted to the DDA regional office dedicated email address, and the DDA will acknowledge receipt of that message and log information into our tracking sheet, and also send an email to the person's coordinator of community services. Next slide, please. The coordinator of community service should also follow the same process in terms of entering a progress note into Ltss with the details contained in the email. They should continue to monitor the provision of services and document context within the Ltss monitoring and follow-up forms, as well as their wellness checks in the progress notes. We would like them to inform the DDA regional office of any discrepancies or concerns related to their follow-up. And again, file an incident report as applicable based on the situation. Next slide, please.
So Donna, let's run a poll for this section.
Okay, can providers exceed the current licensed site capacity without pre-authorization from the DDA as long as DDA is notified? Please select yes, no, or I don't know. It will take a few seconds. Okay, 89% said yes, 7% said no, 4% said I don't know.
Great, thank you, Donna. And the answer to this question is yes. Providers can exceed the current licensed site capacity without pre-authorization from the DDA, and we're just asked that you notify us using the DDA Kovich form number 2.
Okay, I'm now going to read questions that have come up in reference to this chapter into our question box. And this one is for Valerie Roddy. Is there funding to pay for hotel stays for people being isolated or quarantined away from their group home?
Again, the services provided to the individual already have a designated rate to be paid. That the agency would still receive that rate of pay and for the services provided for that individual. There would not be any additional funding provided for hotel stays.
Can you back bill for an individual that the location of the service changed at the beginning of the pandemic?
So again, all of these exceptions and all the guidance that we have been talking about this week all became effective March the 13th. So if there is an issue with an individual who was served in an alternate site, for example, say starting on March the 16th, as noted, the attendance has already been, you can go in and adjust your attendance and recertify it so that that change can be accommodated in the first quarterly payment. However, given this scenario, as we've already stated, if a person is moved to an alternate site, the rate of pay would remain the same. So payment would be received by the agency as it normally does for the provision of that service.
The next one is for you too, Valerie. If a move is necessary for a person, will the DDA be moving the person's record in PCIS?
So that's a good question. I would actually defer that question to Rhonda because in my mind that deals more with the PCP, unless you're talking about a permanent change, and I don't know that we would adjust. I don't know that we would
so,
the new location if it's meant to be temporary.
Correct. The question is, everything stays in LTSS for people's person-centered plan. People get paid through PCIs too. So we would not be changing the people's location in PCIs too, which still, the provider will still be getting paid based through that PCIs2 system. Rhonda, would you like to add anything? And then I'm going to turn it over to Peter in case he wants to add anything. Rhonda?
I agree. Yes, Patricia, I agree. If it's a temporary situation, a temporary alternative site, we will not be making changes to PCIS2 or LTSS. We simply want that notification form, which would give us the address of the person, and so that we're aware of it. But we are not making changes if it's temporary. If it's going to be permanent, then we would want you to notify us, and so we can make adjustments at that time.
Thank you. Peter, would you like to add anything to that?
Yeah, that sounds exactly as I understand things.
Thank you, Peter. All right, the next question says, is there a reasonable number for exceeding site capacity? If a site is licensed for 2 people, exceeding that capacity by 8, is that reasonable?
So that's a great question, and we would ask that providers, as they're looking at their options to support people in their licensed site, really look at the accommodations and the rooms that you have. If you have a large home that has the ability to support 8 people, maybe that would be appropriate. But if you have a 3-bedroom home and you're trying to support 8 people, that may not be appropriate. So again, it's a case-by-case basis. And that's why we would be wanting the notification and having our coordinators of community services doing that follow-up and monitoring related to how services are being delivered.
If a family member has taken individual in traditional residential to the family home, should the provider complete Form 2?
Yes, the provider should complete Form 2.
If you are using a parent as a staff and want to retroactively hire them, can you still pay them even if you are just now doing the background check since the Appendix K was only recently approved?
That's a good question. We'll have to take that under consideration.
Is there any funding for direct support professionals who the agency has provided hotel accommodations to keep the DSPs healthy until their next shift? Just curious.
No.
Valerie?
Oh, no, there is no additional funding.
Okay, so there's a clarification for that last question that Rhonda said we'll have to take it into consideration. It says, meaning can you pay them from the time they had their adult child in their care?
And so what we have in our guidance and shared today is at minimum that there needs to be the abbreviated criminal background check. And so I think the initial question was, if you got that today, could you pay for them for previous days? And that's where we would have to take that under consideration.
What if a family member who has agreed to provide supplemental support cannot pass the OIG background checks?
So the criminal background check is not associated with the OIG, the Office of the Inspector General. If they're not able to meet the standards, then they would not be eligible for hire as a staff member.
Okay. Can you expand on the term process for an abbreviated background check? Has the Department of Public Safety and Correctional Services relaxed the standard of requiring fingerprinting?
So that's a great question. It's from my understanding, no, that has not been laxed. I know initially that some of the sites for fingerprinting was initially closed, but it's my understanding that the fingerprinting offices are open and available to provide that service. What we noted in our Appendix K provision that in order to start services immediately, that the abbreviated background check could be completed, but we still required the full background check to be completed as per the waiver document.
I'm still a little confused. Are you saying that everything except background checks can be waived for family members as employees?
Yes, in general, that's what we're saying based on the participant's decision related to that or the provider that's hiring them. Remember, staff, relatives and legally responsible individuals are being hired to provide a Medicaid service. And so the participant and the provider would be the ultimate one making the decision as to whether they want to waive some or all based on the provisions approved in Appendix K.
Is this the same for people in self-direction? What should the FMS do in reference to background checks for families?
Yes, the same applies for people in self-directed services. An abbreviated background check could be completed initially, and then the full background check is required.
Okay, I'm going to read one more, and then I'm going to go to the next chapter. Can you tell us when will, okay, let me read this. if we increase our capacity in a home, say license for 3, but we have an extra bedroom, so it makes it 4, how long until we need to return it to a 3-person home?
That's a great question. And so under Appendix K, and as we've been sharing in this guidance and today, you would notify us that you're exceeding the capacity, going from 3 to 4. You could provide services and support to another individual in that 4th home or that 4th bedroom. And then after the state of emergency, the end of the Appendix K, then that would need to return back to 3. If you choose to seek to license that additional bed, then you would need to reach out to the Office of Healthcare Quality at that time.
What is the process for the abbreviated background check for the self-directions by the FMS?
The fiscal management service provider could utilize the different local and community commercial entities that are available where they could enter that information, as we mentioned before, the person's name, their social security number, and the date of birth to get initial feedback related to criminal background.
Okay, Rhonda, I'm now going to turn it over for the next chapter.
Great, thank you. Our next topic relates to the ability to exceed group size and 1-to-1 and 2-to-1 exceptions. And so the participant to staff ratio outlined in the participant person-centered plan, meaning specifically 1-to-1 or 2-to-1, may be exceeded due to staff shortages. Providers shall assess the needs of the person being supported for 1-to-1 and 2-to-1 to identify the maximum staffing ratio to safely support the person in their home. DDA encourages teams to use person-centered thinking skills to discuss each participant's risk factors and ways to mitigate those risks, including what technology, environmental, and staff supports will be provided to mitigate those risks during specific activities and situations. The emphasis in the conversation related to these must be around why the supports are being provided, not the number of hours and people, but the reason why staff are there. In addition, in our guidance, you'll see for the community development services, you can exceed the up to 4 people in a group if you're providing services remotely. Next slide, please. Related to the exception to 1-to-1 and 2-to-1 staffing, providers must ensure that the 1-to-1 and 2-to-1 supports are provided unless otherwise authorized by the DDA regional office through this exception process we're going to discuss. Providers must immediately call the DDA regional office when they're unable to provide any staffing to support health and safety of participants that they're supporting. Next slide, please. Providers must submit an incident report into PCIS2 when the 1-to-1 or 2-to-1 service requirements were not met and an exception was not authorized by the DDA. For these types of incidents, one incident report can be submitted for a 24-hour period. In other words, if you were unable to meet the staff ratio in the morning and also unable to meet the staff ratio in the afternoon, you do not need to submit 2 incident reports. You could submit 1 for the day, indicating the specific times that you were unable to meet those requirements. Please note that providers must also file incident reports as per DDA's policy on reportable incidents and investigation for all other incident types, such as injuries and deaths and other ones outlined in the policy. Next slide, please. Providers should maintain documentation and correspondence and other records demonstrating their inability to meet required staffing ratios, and also documentation related to what actions were taken to mitigate staffing shortages and maintain evidence for why actions were taken. Next slide, please. Providers that wish to request authorization to exceed the person's currently authorized 1-to-1 or 2-to-1 staffing support should complete the DDA COVID-19 Staff Exceptions Request Form, DDA COVID Form number 3. They're going to send the form again to the secured email to the DDA Regional Office dedicated email account with the attestation that the staff ratio exception will support the health and safety needs of the person affected. The email subject line should read the name of the provider, hyphen with COVID-19 staff ratio, and then insert the date. Next slide, please. This is the COVID-19 form to be used for this notification and request for authorization from DDA to exceed the staff ratio. This form is to be completed for a specific person. Multiple people should not be listed on this form. Providers will enter the person-specific information, including the LTSS ID number if known, PCIS2 ID number, first and last name of the person. They shall enter the pre-COVID staff ratio as authorized in the person's person-centered plan, such as a 1-to-1 or 2-to-1. They will then enter the new proposed staff ratio, for example, maybe a 1-to-2, and then enter information as to how the person's need is currently being met and why that is unintendable. Enter information as to what the risks are if the needs cannot be met, and then enter any additional comments in the comment box as applicable. The agency director shall enter their name, signature, and date. This form again is submitted to the DDA dedicated email address listed in the guidance and also again noted here on the top right-hand side of the slide. DDA will acknowledge receipt of this email from the provider. We will seek additional information as needed to assess the ability to support the person's health and safety with this new staff ratio proposed. We will authorize or deny the request based on the determination. This form will be uploaded into the client's attachment in Ltss Maryland, and we will also send an alert to the participant's coordinator of community services. Next slide, please. Coordinators of community services shall confirm the staff ratio continues to meet a person's health and safety need during their monthly contact and inform the DDA regional office of any discrepancies or concerns. Providers should continue to document staff ratios in their case notes and again submit incident reports as applicable based on the standards we just listed in the recent slides. Next slide, please.
So as noted in the guidance, there are no changes to the billing process. Providers should follow the existing billing process for the service that's being provided based on the staffing ratio as it is authorized in the person's PCP prior to the COVID-19 exceptions. The rate of payment will also remain the same. It will not be changed or adjusted. Next slide, please.
So Donna, let's run a poll for this, our last chapter.
Okay. Providers must submit an incident report when 1-to-1 or 2-to-1 services were not met. An exception was not authorized by DDA. Please select yes, no, or I don't know. And take a few seconds for that. %, said yes, 4% said no, 4% said I don't know.
And the answer is yes. Providers must submit an incident report when 1-to-1 or 2-to-1 services were not met and an exception was not authorized by the DDA.
Thank you, Rhonda. Really appreciate that. I just wanted to remind everybody to please make sure that you familiarize yourself with the information that is on the DDA website and submit any additional questions to the DDA toolkit at maryland.gov email, and will be posted all frequently asked questions on the DDA website. You may also want to take a look at the FAQs before submitting a question, as it may already be an answer within that document. Again, our website has, some of you have put in the question box, where can you find this information, where are the forms? Everything is on the DDA website, which is linked here. We have the at-a-glance documents. We have the topic-specific guidance memorandums that you can refer to that talk step-by-step of what's allowable, what are the requirements, what forms to complete. And then we also have all the webinar presentations that we've done in reference to Appendix K. We already have the May 5th and the May 6th posted, and we will have today's by the end of close today. I'm now going to open it up to questions in the chat box. So let me do that real quick and see what's come up since our last opening of that. Are CCSs required to follow up with the provider after each incident report for staff ratios exceeding?
CCSs, yes, should follow up as per the policy on reportable incident investigation for incidents that are submitted.
Appendix K says that we can deviate from staffing as outlined in the person's PCP, and the requirements to submit an incident report has been suspended unless it results in failure to provide care. Does this not apply to one-on-one and two-to-one staffing?
That's a great question. In Appendix K, we included language to provide the option for the DDA to have flexibility related to our incident management system. And so as we shared today, the exception we're making is if a one-to-one staffing ratio was not provided and an exception was not granted by the regional office, and it happened twice during the day or 3 times during the day, our exception to our incident reporting system is that you would not have to file 2 or 3 incidents, but you would need to file 1 for the whole day accounting for these.
This was a long one, so I'm gonna read it slow. If we had been providing one-on-one supports to someone under supported employment in a paid job, and now we want to provide one-on-two group services to practice interviewing and work on employment social skills, do we need to make a request to make a staff exception? The client's health and safety needs are well met, as they had a full-time paid independent job that they got laid off from.
So that's a great question. And under supported employment, our supported employment services are a one-to-one service. It's not a group service such as our CDS, day habilitation, and our community living or residential services. So under that situation, you would not need to request an exception because that service is designed to be one-to-one.
Do we need to go retroactively and fill out form number 3 and incident reports for all instances where we were out of ratio?
You would need to complete this new notification and authorization request form specific to one-to-one and two-to-one services that have been authorized under our residential services. That needs to be completed, and incident reports should be provided if that was not met.
So people are saying that the questions haven't been updated since April 3rd. You may be looking at the wrong section. And before we end this webinar, I'm actually going to go live and show you the website so that you can see where you can find all of this information, because I've got lots of questions on the question box about where to find this. So please indulge me as I show you guys before we end today's session. In which executive order does it state the certification holders have 90 days to renew? Maryland Board of Nursing continues to indicate they have until 30 days after the state of emergency has ended, since Maryland Board of Nursing is the licensed body. Which should we follow?
So that's a great question, and we may not have communicated that or stated that well in our presentation. You must follow the Maryland Board of Nursing. In the governor's executive order, and we have a link to the governor's executive order in our DDA memo and guidance dedicated page. He has provided under the executive order for people to continue to practice and extend licensing and certifications for expired services and supports across various agencies. What we were talking about today was, in addition to those executive orders that have come from the governor or directives from the Maryland Board of Nursing, in terms of some of our specific training and onboarding requirements, we have temporarily provided the option for providers and participant self-directing services to make an exception to meeting those standards, but must be in compliance within certain time frames. I would ask that you look at the guidance again, because some of the guidance requires that provisions be met within 90 days or 120 days. Some of them refer to after initially starting services, and others will refer to after the state of emergency. The authority that you should always follow would be from the governor and his executive orders, and then the Maryland Board of Nursing.
CCSs were previously instructed to conduct weekly wellness checks. This presentation states CCSs are conducting monthly contacts in the ratio exceptions request slide. Please clarify.
So that's a great question. And what I was trying to communicate was that we want CCSs, as they're doing their monitoring and provision of services, during the monthly and the wellness checks, you may recall I mentioned both of them, to indicate information, the progress notes, and to alert us to discrepancies. As we move forward, the weekly wellness checks may be extended to every 2 weeks, but we know that we want you to continue to monitor and support and follow up with people. So just to rephrase, continue your weekly wellness check and complete information in the LTSS to include monitoring and follow-up as already directed.
Before now, in this procedure, if you could not provide one-on-one, but were able to conduct how you were able to meet health and safety, well, DDA advised OHCQ. In the past, this type of incidents would be fine of neglect and trigger a Office of the Attorney General audits and a clawback of funds.
So that's a great question. And so what we're trying to do with the Appendix K and in this state of emergency, recognizing that in some situations, the one-to-one and two-to-one authorized support may be challenging due to staff availability, positive cases or determinations of COVID-19 and such. We wanted to be able to support providers in the event that they felt with other appropriate supports, maybe technology, or maybe on a temporary basis, or maybe for only a few hours during the day, to request the ability to have an exception to the one-to-one or two-to-one, for instance, maybe supporting someone in a 1-to-2 by using a request form that could be authorized. If it's authorized, we will be documenting that information, and we can share that with the Office of Healthcare Quality, and you will have that in your documents, because we're going to send the notification and decision back to you as documentation of authority that we had granted to that exception. In that case, then, any follow-up related to audits or other investigations, that would have the documentation for which we would support if it was authorized by the DDA.
DDA has been informed since the beginning that ratios may not be met, and this is the first we are hearing these requirements. We may have 8 weeks of incident reports to do. Isn't there another option available for this? Thank you. We will take that into consideration and see what effective day we will do for that. Rhonda, would you like to add anything to that?
No, we'll, as you said, Patricia, we'll look at options that we can utilize and coordinate with our Medicaid agency related to their requirements.
Okay. I'm going to read a couple of more because there's a lot about the questions, the FAQs not being on the website. Since you only just clarified that providers had to complete incident reports for one-on-one exceptions, please reconsider the requirements of incident reporting needing to file prior to today. We will definitely do that. Thank you for that recommendation. For CDS services, if we want to move from one-on-one supports at a volunteer job to one-on-two remote supports, do we need to make a request from staff exceptions?
If the person is authorized one-to-one dedicated supports, then yes, you should request that authorization. If you're going to be providing services remotely, you know, those are options too that can be provided related to CDS. But if a person has in their PCP dedicated hours, dedicated one-to-one or two-to-one, and you're not going to meet that, or you feel you can provide it in a different ratio, then you should notify us and make that request for an authorization.
Some one-on-one ratios in personal supports in community living are in place to support social activities, not for health and safety. Does Form 3 and incident reporting apply when exceeding this type of one-on-one?
My answer is yes. And in that information, you would indicate why you're making that exception, because possibly those social activities are not occurring at this time, and so therefore those one-to-one supports are not needed. But we'll take that back and think it through a little bit more and see what options are available.
Can you elaborate on rehabilitation one-on-one versus rehabilitation without one-on-one telecommunicating?
Yes. Under the meaningful day services and other services, per the Secretary's order, services can be provided telephonically or remotely. Therefore, if you're funded for a one-to-one service and you're providing that service telephonically or remotely, you would then still be providing that service in a one-to-one, but it would just be remotely or telephonically. In that situation, you would not need to submit any notification to us.
This may be a Valerie question. Please explain how the billing will work if there are two people in a alternative living unit that gets one-on-one supports but are also participating in distance learning option with their day provider.
So as we discussed probably on Tuesday's webcast, there are a couple of issues. So I think one deals with the additional hours that have been assigned to each house to cover when day services cannot be provided. That rate will continue to be paid as the billing is submitted, or when they do the attendance and certify that attendance, then the billing, that higher rate will be paid. In terms of the day providers would do their billing based on the criteria that has been established, that they provide at least 1 hour of service in order to bill for the day.
If a provider submits Form 3 for staffing ratio exceptions with a backdated effective date of 3/13/20, then incident reports will not be needed, correct?
Yes, we'll take that under consideration, but I think that that's a good suggestion.
Okay, there's no more questions in the chat question box. I'm going to go ahead and close this so we can show the website. So I don't know what I have open in my computer, so I apologize in advance if crazy stuff show up. but let's try this. Let me just see if I can just go real quick to my browser and look at our DDA website. All right, can you guys see my screen?
Yes, Patricia,
Rhonda,
we
can you
see your
respond?
screen. Yes, we can see
Okay,
it.
so this is, thank you. So this is where our website is right here. We go to this COVID-19 information. You click there, and then you go where it says DDA Appendix K. You click here, and then when you click here, you will see that we have all the letters that's been approved by the CMS, and also toolkits, and then you have the federal application. Then you have all the at a glance information that we share, and even if it's been revised in the day that it was revised, and then all the memos that went out from 1 all the way to 11 that we concluding today. You see that, and then you'll see that there'll be some revised things for revising. Then right here, frequently asked questions, you click here, May 5th, you open it up, and then you just have to do this little turning thing, and then it turns right here. Now, some folks have said, is there a way that we can do a search this a little bit different? So we're working on that, but right now this is what we have. And so we just do Control F, and we'll type, like, say, personal supports, and then we hope supports. And then we just hope that everything with personal supports then shows up. But we're not able to do that. So we're just working on a way that we can do that search button, but we did hear you, and we're gonna work on that. So that's where the questions are. There is 41 pages of questions. We try to break it into a specific section. If you look at it, just as we go through it, there's some billing questions. It'll have the questions, it'll have the answer, and it'll have the date that it was updated, so you can see how current or old it is. Okay, so that's where that's at. And then forms, these are where all the forms are. They're all current. So here's all the forms that you would have in reference to COVID-19, the self-direction form that we talked about on yesterday. So everything's on this. And then here, if you missed any webinars, so far we have the one on May 5th and on May 6th. So that's pretty much where we have all this information. This is specific to Appendix K now. Now, if you want specific information about updates from the secretary or updates from the governor's office, Medicaid updates, that's all in here. And then we have specific information about providers and guidance. So here is the other section where we have information specific to Appendix K, congregate living, essential staffing, about the GO teams, about Ament, you talked about the Maryland Board of Nursing, information about meaningful day, the PPE, personal protective equipment, our toolkit, information on self-direction, telehealth, and then we broke this down into other things from the Secretary's office and the governor's office. So we're trying to make this as efficient and as user-friendly as possible, so you don't have to do more than 1 or 2 clicks. So Rhonda, is there anything that you'd like me to share on here, or Peter or Valerie, that you think people need to know? We have about 2 more minutes.
Yeah, Patricia, can you go back to Appendix K page?
Sure.
And then if you could go down to just before the at a glance where it says DDA Appendix K provision at a glance, if you could click on that one. This one, just a reminder, is a kind of quick at a glance of the various provisions that we talked about and services that are applicable. So if you want kind of like a quick reference guide, you could look at this in addition to the topic specific at a glance and the topic specific memo guidance.
Okay, so I'm going to just check my chat box one more time, question box, and see if there's any questions from people before we end our webinar for today. Let me just see if there's any more that has come. All right, just a lot of thank yous. Thank yous. All right, everyone. So I really would like to thank all of you. We are going to process all the questions we've gotten. We will be determining if we need to do any additional webinars, and then we will in our series that we've had today. So thank you all very much, and be safe, stay well, and practice social distancing.